Shavji, Dr. Klepetko, thank you so much for allowing me to speak today. Very interesting talk. There's going to be some overlap with the previous talk, but obviously we're going to be focusing a little bit more on the aspect of deciding whether or not to go on to ECMO or deciding whether or not to proceed from ECMO to transplant, which is something that comes up in a lot of centers, especially smaller centers now. They're starting to put people on ECMO as opposed to, for instance, a robust experience from a couple of very large centers that are very experienced in it. By way of overview, I'll talk a little bit about the background of the landscape, a couple of technical notes. I won't go too into that, and then the outcomes with an emphasis on should the patient proceed to ECMO, if so, should they proceed to transplant. So the current landscape, as was mentioned before, right now we have, in 2015, 4.7% of patients on ECMO at the time of transplant, which is a number that's been steadily rising over the past couple of years. And that's probably going to continue to increase. If you look at the number of patients being listed above the age of 65, that is going up. LAS scores are going up. Number of patients with ILD is going up. So we're getting a sicker and sicker cohort that we're having to deal with for transplantation. ECMO is going to become more and more something that we have to consider. So just by way of case presentation, a 48-year-old gentleman with a history of cystic fibrosis, multiple exacerbations, progressive decline in lung function. He presents with fevers, cough, and shortness of breath on high-flow oxygen and face mask, which are insufficient to maintain his oxygen levels. Also hypotensive and elevated creatinine. This is not an uncommon scenario, although now we're even faced with 70-year-olds with ILD with a similar picture, 65-year-olds with ILD with a similar picture. So initially, non-invasive or invasive ventilation is usually going to be the upfront strategy, and organ support. We try to determine reversibility. Is this something that's going to reverse? Is it someone who's a candidate for transplant? Are they already on your transplant waiting list? Should you start urgent listing for this patient? Should you initiate ECMO? And is it going to be a bridge to transplant definitely, or is it going to be a bridge to decision? So just briefly reviewing again the indications for ECMO: refractory hypoxemia, hypercapnia, despite optimal ventilator support and medical management. So as a default, most patients are going to be considered for ECMO. We're a little liberal about initiating that with few exceptions. The goals for ECMO are primarily optimization of the patient and to provide you with time. These are the two things that we need in order to bridge a person to transplant and to decide whether or not they're going to be a good lung transplant candidate. We have to balance the risks and benefits of aggressive medical management and trying to hold off ECMO versus the risks associated with ECMO. There are, as mentioned, a couple of contraindications that factor into the decision-making for even putting someone on ECMO. Sometimes it's very obvious. Sometimes it's definitely more of a gray area. If a person is ineligible for transplant for obvious reasons with an irreversible pulmonary process, should probably not be started on ECMO as a bridge to decision nor transplant. If they have irreversible end organ, sepsis, and bacteremia, contraindications to anticoagulation. Uncontrolled metastatic disease, terminal illness with otherwise that is otherwise not treatable by transplant, or acute intracerebral bleeds. These might be relatively straightforward cases that you would not initiate ECMO for, not even for decision. Relative becomes more challenging. Age greater than 65, limitations in vascular access, obesity, frailty, they've been on the ventilator for more days, allosensitization with prolonged anticipated wait list time. These are a little bit more gray areas, and they're unfortunately the ones that we're faced with more and more. So as we go on with the talk, I'll try to talk about specific favorable and unfavorable factors that help us one way or the other. Additional considerations are timing. Sometimes it's better to consider the ECMO early. Is it a bridge to recovery versus transplant or decision? You need a multidisciplinary team involved in this process from the very beginning, with the surgeon, a medical team, critical care, social worker, physical therapy. Ambulation is fantastic, as you saw the videos in the last slide. If you can get them to that type of a circuit, clearly better. We have to consider the resources and institutional perspective. I think there's no question that even though a lot of centers show excellent outcomes after transplants for patients on ECMO, they are definitely higher risk. You have to give a little bit of consideration as to how your institution will view that. And then family perspectives, absolutely. Just as far as a quick review of technical considerations, ECMO obviously oxygenates the blood. VV, veno-venous, VA, or VVA are the three most common units that are used when we talk specifically about ECMO. VV, typically for inability to oxygenate or remove CO2 with a normal cardiac function and limited pulmonary vascular resistance. The dual cannula concept is usually the most straightforward in most settings, where you have a drainage cannula in the vein and then inflow of oxygenated blood from above, either from the subclavian or the IJ. However, it does lead to pretty predictable oxygenation, less recirculation. However, immobility is a major issue with that. You can't get the patient up, and there can be venous complications if it's done emergently, especially in the absence of TEE echo guidance. The Avalon cannula is obviously a very popular mode to help somebody with ambulation. This is a dual chamber cannula that is a single cannula that goes in through the IJ. I'm sure everybody in the room is familiar with it, but with that single cannula you can drain and deliver oxygenated blood into the tricuspid valve. This is becoming more and more common to use. It does allow you to get more of an ambulatory configuration, which is nice. Probably the most common ambulatory mode to use. Veno-arterial ECMO is used for refractory hypoxemia, hypercapnia, despite optimal vent support and medical management. It's used most commonly when folks have poor cardiac function or severe hemodynamic shock, elevated pulmonary vascular resistance. Veno-arterial, the most common, again, ECMO circuit is probably going to be in the groins, separating the left and the right limb and including a reperfusion cannula. The disadvantages here is that you can have limb complications, immobility. You can have Harlequin syndrome with mixing of blood at about the mid-descending aorta. All these technical complications become very important as you have a patient that you're bridging to a decision. Because a lot of times we're trying to decide, are they going to be good enough shape for transplant or not? And the choices that you make up front from a technical aspect can very much factor into that. If there's a lot of bleeding, a lot of blood loss, that's going to change your perspective as the patient goes on ECMO. There are many fantastic central sport models from the Columbia Group and others, and many different sophisticated ways to establishing ECMO. That ideally, you get the most reliable perfusion, most reliable oxygenation, so that you can keep the patient in the most optimized form for as long as possible. Generally, we try to rest the lungs, keep some PEEP for recruitment. We're assessing periodically for recovery, attempt extubation, consider early tracheostomy, as was mentioned before, optimizing coag status, nutrition, physical therapy, optimizing end-organ perfusion, and reestablishing goals of care on a daily basis, rounding frequently with multidisciplinary teams to assess every day, is the patient still a candidate for transplant? Should we continue to proceed with this patient on the wait list? Several complications have to be considered: frequently bleeding, physical deconditioning, renal dysfunction, infection, and access complications may all contribute to either delisting or to changing your perspective on whether to proceed. So what is the likelihood of transplant? And if transplanted, what is the likelihood of a successful outcome? Because that's essentially what you're deciding when you're thinking about ECMO for decision. So several series have been published, many of which were discussed before. I want to try to focus a little bit on a summary of favorable versus unfavorable factors that you can take home as kind of take-home rules of thumb for this. So when we look at Hyanga's group from the Pittsburgh experience in 2015, reviewing the UNOS database, they actually show pretty good news. So in 2000 and 2002, there was a significantly worse outcomes for patients on ECMO who then got transplanted compared to those who were not on ECMO and got transplanted. As Dr. Khashabji noted, more recently, that experience has been narrowing the survival curves. So clearly, we're either getting better at deciding who to transplant, or our cannulating modalities are getting better, or our transplantation details are getting better. My suspicion is that we're getting better at selecting the patients that are going to do well after transplant. But you definitely see a decrease in the hazard ratio for patients being transplanted off of ECMO. Patients bridged in that series had higher risk of dialysis-dependent renal failure, suggesting that there is increased morbidity and resource utilization. Patients older than 35 and those with cystic fibrosis or disease categories other than ILD or COPD did worse after lung transplant. Does volume matter? And a subsequent analysis in 2016 showed that centers that transplant more than 15 patients off of ECMO every year do significantly better than those who transplant 1 to 5 off of ECMO. It's something to consider. The patients in your hospital on ECMO, should you be considering partnering with another center that's doing more, or is your institution willing to absorb the risk? The group from Vienna reported in this series from several years back 90% success rate for bridging, which is fantastic to transplantation, but there is an associated mortality rate of about 24% in this series. This was earlier on of in-hospital mortality after retransplantation. After transplantation, median bridging time was 5 days. Very interestingly, the 5-year survival was the same, as Dr. Khoshabji had mentioned before, when patients survive beyond the first 3 months. So again, it's important to try to find out which patients are going to make it past those first 3 months, and those are definitely the ones that you should continue to consider for transplantation off of ECMO. In a separate study by Weig and colleagues in 2013, looked at parameters associated with outcomes of 50% success rate to transplant. Median time was 33 days. Several potential risk factors, higher bilirubin levels, higher pulmonary pressures, higher SOFA scores, were all associated with significantly worse outcomes after transplantation. So those are 3, at least, small points that you can use when making your decision to proceed to transplantation during the decision period. In this publication out of CHEST in 2013, went into looking at a couple of other factors associated with better or worse long-term outcomes after transplantation in patients that were bridged. Those who were on the list or on ECMO less than 14 days had the best survival, actually very good, compared to those that were on for greater than 14 days. And predictably, the ones that were on for greater than 14 days had higher SOFA scores as well. Inter-transplant year greater than 2 years for retransplantation. Retransplantation, clearly higher risk group. If the inter-transplant years are greater than 2, however, they do pretty well. And if they are awake on ECMO, they do definitely better than those who are not awake and participating with physical therapy. So it's something to consider when you're faced with that very challenging cohort of patients that are retransplants. Awake ECMO does seem to be better in almost every series that we get, and it makes sense. In this series from the group at Columbia, 9-year experience, 55% success rate for bridging to transplant. And I thought it was very interesting in this study. There were about 22, 23 patients that were delisted, 9 that died before transplant. So there's probably more and more of an active decision being made about who is no longer going to benefit, who is so-called futile, who just will not gain from a transplant. And the factors that were identified as being predictive of that were inotrope or vasopressor use, elevated SOFA scores, patients who were ambulating were more likely to make it to transplant. Cystic fibrosis had the most favorable prognosis. Need for renal replacement was not good. Interstitial lung disease had the worst rate of survival after lung transplantation. So in summary, looking at some of the various studies that have been published, there's no excellent data on this, but there are some rules of thumb that when you're looking at a patient who's on ECMO and you're deciding whether or not to proceed to transplant, there are favorable factors and there are unfavorable factors. Favorable factors would be patients that are a bit younger, less than 50 years of age, normal or marginally elevated total bilirubin, normal or mildly elevated pulmonary artery pressures, less than 14-day duration on ECMO, low SOFA scores, non-invasive ventilation if they're awake, if they're able to participate in physical therapy. Those are favorable factors. And I always tell patients and their families that if they're in this group, we'll stay there as long as it takes. I don't necessarily use a 14-day cutoff per se, but it starts factoring in if it's going on for too long. Whereas unfavorable factors would be older patients, age greater than 60, total bili starting to rise up higher than 3, there's severe pulmonary hypertension, they're on ECMO now for longer than 14 days, prolonged mechanical ventilation, prolonged immobility, elevated SOFA scores. If they're having major bleeding complications, technical complications from the ECMO, infectious or end organ complications, if they're requiring dialysis, and if they're a retransplant with a short retransplant interval period. Those are unfavorable factors, ones that we're going to have serious discussions about whether to proceed with those or not. Thank you.